I'm Peter Block for On the Scene here at TCT 2014 in Washington, D.C., and it is day 2. We continue to have lots of late-breaking clinical trials, and I'm here with Deepak Bhatt, who is from the Brigham and Women's Hospital, of course, in Boston. Deepak, tell me about the trials. We have Absorb, we have RIBS-4, we have DK Crush. Let's talk about the first one, which would be Absorb 2.
Sure, I thought the Absorb trial is very interesting. Of course, this is randomizing patients to the bioabsorbable stent versus a second-generation drug-eluting stent. And these are really some of the first high-quality randomized clinical trial data. We've got 1-year data showing that the bioabsorbable stent performed very well, no difference overall in the rate of major adverse cardiovascular events, some reduction in nitrate use in favor of the bioabsorbable stent that was interesting, needs to be confirmed in further studies. And just one point, there was a slightly higher number of stent thromboses in the bioabsorbable stent, though the overall number was still pretty low.
Yeah, but the overall outcome is pretty even, isn't it, Deepak? And I just wonder whether or not, the difference in the mechanics of putting these stents in continues to be real. They're a little bulkier, a little bit more difficult, perhaps. I perhaps shouldn't say that since I've not used one, but everyone says they're a little bit trickier.
They're a little bulkier, a little harder to deliver. They're thicker struts, so some had hypothesized there might be higher rates, say, of periprocedural MI, and there was slightly higher CKMB release in this trial with the bioresorbable stent, though not periprocedural MI per, say, the SKY definitions. So I think what we really need is longer-term follow-up to see if there is a benefit that emerges or any risk, and likewise just larger number of patients, just to make sure that stent thrombosis signal that was noted isn't anything to really worry about.
Yeah, well, the issue here really is recurrence in stent thrombosis, isn't it? And we'll see whether or not over time, when these data continue to roll out, there's any difference. Let's move on. Let's move on to RIBS-4, a drug-eluting balloon. I was going to say DEB, but I really shouldn't. Drug-eluting balloon versus a second-generation drug-eluting stent.
For in-stent restenosis of drug-eluting stents.
Right. And so an interesting trial that seems to show that if you're going to put a stent in, you may as well put a stent in. I guess that's the short version.
I thought the results were really interesting. I actually thought the drug-eluting balloon would quote-unquote win, but in fact the second-generation drug-eluting stent seemed better than the paclitaxel-coated balloon for treating DES in-stent restenosis. So it seems like a simple, easy solution. Just go ahead and put a second-generation drug-eluting stent in there.
Yeah. Okay. So last trial that is sort of interesting is the DK Crush trial. Now that's a trial where the whole question is, do we or do we not stent the bifurcation, the LAD diagonal lesion of an LAD diagonal combination stenosis? And that has been a thorn in the side of interventional cardiologists for a long time now. The DK Crush tried to figure out whether or not FFRing this versus just an angiographic, I think I'll do it kind of thing would make a difference.
Absolutely, great study, and it didn't show any difference between angiographic guidance versus IVUS guidance in this particular, versus FFR guidance in this particular situation. But I think there's still an important message here because, you and I were chatting before, both of us favor not stenting that side branch unless there's a degradation in TIMI flow or unless it looks really, really tight. And it reminds me of what Floyd Loop used to say in the OR. He used to say, patients never die of diag disease, which isn't totally true. Of course, you could VFib from a diag occlusion, but in general, his point was, as a surgeon, he made sure that lima was put to the LAD, but he wouldn't necessarily obsess over the diagonal branches. And I think as interventionalists, sometimes we obsess over angiographic perfection. So if you're one of those interventionalists that is just annoyed by that 50% osteal diag lesion after you've stented the LAD, then I think you should FFR it to convince yourself to leave it alone. I
think that's a great strategy. So if you're a little bit worried about it, if you're not worried about it, don't do it. I think that's fair. But if you're worried about it, FFR it, and if it's less than 0.8, I guess it's okay to put a stent in. But if it's certainly above 0.8, stay away from it. Let Mother Nature take care of the stenosis.
That's right.
Thanks, Deepak.